Hello everyone, my name is Alina Kravitsky and I would like to extend a very special thank you to Dr. Marie Salama and the whole Dental XP team for giving me an opportunity to share my humble knowledge and some of my experience here with you. Today I would like to share with you a topic that I'm very passionate about. Fibrin-assisted soft tissue promotion, FASTP. And before I share this topic with you, I'd like to tell you a little story of how it was born. I am very fortunate to share the same partner in personal life and my professional life. My husband, Dr. Alexander Alam, and I, ever since we met at USC about 17 years ago, spent a considerable amount of time discussing cases, literature, trying to always reinvent and improve ourselves and treatment for our patients. And one of those really interesting discussions happened when I was pregnant with our first daughter, Amelia, about 4.5 years ago. My husband was fascinated with the process of how a human being is made. And he couldn't believe that a woman in a matter of 9 months can create a whole human being with fully developed organs. And he felt at that time that he really shouldn't have any problem creating some hard or soft tissue in periodontics. So this got us really thinking. And at the same time, concurrently, my husband came across a gentleman by the name of Dr. Joseph Shukroon, who was from his hometown, Nice, France, who was doing really incredibly interesting research on effects of platelet-rich fibrin on wound healing in diabetic patients and burn victims. And he was getting incredibly wonderful results. We got really fascinated with this, and my husband just didn't hesitate for 1 second, went on Facebook and immediately contacted Dr. Shukroon, and at that moment our collaboration started. Just for the sake of the discussion, I'd like to share with you an example which will help you understand our thinking process at the time. Let's pretend that we have this young lady in your dental practice, and she presents to you with a very large carious lesion in the molar. Well, let's say that you are the best dentist and you have the best dental laboratory and the best finished margins. No matter what you do for this patient here, we know that down the line, this restoration or dental implant most probably will fail, no matter how well it's done during the long lifetime span that she has to live through. Now, what if for 1 second we pretended that we could restore this patient and this tooth with real dentin and enamel instead of a restoration? How would we really feel about ourselves as healthcare practitioners? I know that I would probably be very excited about this if I could do it. And then I reminded myself that we actually do this routinely in periodontal plastic surgery, specifically with connective tissue grafting on a daily basis for many years. We're able to stimulate patients' own tissues to regenerate themselves, to regenerate attachment apparatus ad integrum to its original form, function, and aesthetics when we're grafting recessions, gingival recessions with connective tissue graft. Now, even though connective tissue graft is an incredible treatment option for our patients with gingival recession, we're also aware of some of the shortcomings and some of the difficulties that we come across when we treat our patients with this treatment modality. The main problem with the connective tissue grafting is the morbidity, which occurs in the donor side, and also the quantity of the tissue that we can harvest at one given time, which usually results in multiple surgeries when treating multiple recession defects. So for this reason, recently market has drifted a little bit more towards allografts and xenografts. But even with these treatment modalities and products, we have some limitations. The main limitation with those is higher cost, the quality of the tissue that we get at the end of the grafting, as well as some disease transmission questions. Now, what would be an ideal graft material for us periodontists? Well, for a periodontist, an ideal material as a gold standard would be of autogenous origin, would have a very low cost, would have unlimited quantity, and very high quality of tissue that results. What if we had a product or a material that was very close to this? And to our group today, the only thing that is the closest to this ideal is platelet-rich fibrin. The first paper Dr. Shukroon and my husband, Dr. Alam, have published was in 2013, and ever since then, we've been collaborating and using platelet-rich fibrin, continuously trying to improve the technique and the outcomes. Now, this isn't the first time we're hearing about platelet concentrates. Platelet concentrates actually have been on the market for over 17 years. The first one that we all heard actually was proposed by Professor Marks about in 1998, was called platelet-rich plasma, or PRP. But the results were a little controversial. And later, several new generations of platelet concentrates came on the market, and historically PRGF, later platelet-rich fibrin, and the newest ones that we'll talk about more in this presentation are advanced platelet-rich fibrin and an injectable version of it. So what is this PRF concept? The PRF concept is taking autogenous patient's own fibrin clot and transferring it or transplanting it to an area of a defect, of recession, stimulating platelets that are in the fibrin clot to release growth factors and have leukocyte cells that release growth factors, therefore stimulating new blood vessel formation, stimulating cells to produce and form new tissues, and therefore improve and speed up the wound healing process. Now, let's take a look at these two major platelet concentrates, platelet-rich fibrin versus platelet-rich plasma, the original one, and look at the differences between these two. Let's first start with the PRP. PRP and PRF both have similar contents of cells. They both have platelets and leukocytes. However, with PRF, we have a higher content of platelets and leukocytes. PRP requires a double spin, so it takes a little bit longer to prepare, whereas PRF requires a single spin in a centrifuge machine. The tubes are the same. However, with PRP, the tube is coated inside with anticoagulant, usually heparin, and platelet-rich fibrin does not have anticoagulant associated with it. Now, the major difference between these two platelet concentrates is in the release time of the growth factors, and this is what I want you to pay attention to in this chart. With PRP, we have a very short release time of growth factors, from 1 to 3 days. Whereas with PRF, we have a sustained, constant release of growth factors over a period of a little bit over 2 weeks. Now, physical properties of these two are also different that make a huge difference in our technique. PRP comes as a liquid and is very difficult to contain in the same area, whereas PRF actually has a physical property of a membrane and is very easy to immobilize and keep in one place. The cost between these two is a little bit different as well. With PRF, we have a much lower cost when it comes to armamentarium. So, platelet-rich fibrin releases multiple soft tissue growth factors. But what's even more interesting is the newer generation of platelet-rich fibrin, advanced platelet-rich fibrin, also has monocytes. Now, monocytes are precursors to macrophages, and to us they're very interesting because they release BMP, bone morphogenetic proteins 2 and 7. So as periodontists, we were very excited about this because this may make a major contribution and play a major role in hard tissue augmentation, not only in soft tissue augmentation. So when we look at this release time of the growth factors that we talked about, the best analogy that I can give you between PRP and PRF is different types of irrigating systems. So with PRP, as we said, we have this 1 to 3 day release of growth factors. So it's kind of like if you have a lawn, and every day on a daily basis, you just take a bucket of water and just pour it over your lawn, and that's how you water it. Now, the difference with the release of growth factors with PRF is more like a great irrigating system where you have a system that delivers drop by drop, sustained, continuous water to your lawn. So when you look at these two, which irrigating system would make more sense? And we know that definitely an irrigation system that has a continuous watering is definitely much more beneficial. And this was very nicely shown. This difference in release of days was shown by Shamlu in 2012. Now, in this study by Dohan in our group, and he actually showed that every single one of those growth factors has a slow release over a period of those 14 to 15 days. So every single one of them continuously gets released. Now, what's even more interesting is that every growth factor actually plays a role in different stage of wound healing. So therefore, platelet-rich fibrin is able to enhance and improve not only the whole outcome, but every single stage of the wound healing process. So what about different types of PRF that are out there in the market? I'm sure all of you are familiar with different names that are out there. So it's very important for us to understand the differences between those when we make a decision on which one to use as a graft for our patient. So let's take a look at the LPRF. LPRF is very similar to original standard platelet-rich fibrin or similar to CGF. So it has a similar content, platelets and leukocytes, and it has a much faster spin with a timing of 12 minutes, utilizing similar glass tubes. Now, when we go to the newer generation, advanced platelet-rich fibrin, now we're adding those monocyte cells to our cellular content and also reduce our speed of spinning in a centrifuge by about half. The timing is similar here. Now take a look at the next generation of advanced platelet-rich fibrin. We have the same similar content of the cells. However, not only did we reduce the time of spin by half, but we also reduced our time of the spin by half using similar tubes, which allows us to actually trap a lot more concentration of these growth factors. And the last platelet-rich fibrin generation that you're seeing here is called IPRF, or injectable PRF. And this platelet-rich fibrin actually has very, very interesting content. We don't only have all the cells that we talked about, but we also are able to trap a small amount of autogenous stem cells from the patient. Now you can notice here that we're utilizing different types of tube, plastic tubes, and also cut down our timing by another half and our speed by another half. So the speed and the timing of the spin makes a big difference in terms of how much of those growth factors you're getting and how clinically significant they will become when it comes to grafting. In this study by Dr. Gennady and Shukrun, the study came from Germany, from our group, they compared standard platelet-rich fibrin with the newer generation of advanced platelet-rich fibrin. And they found that the advanced platelet-rich fibrin has more granulocytes and therefore improves function of monocytes and improves vascularization. They also showed in the study that there is a sustained slow release of BMP2 of 100 picogram per milliliter per day, as well as more than 50% more of